Hello and welcome to the Women Leaders in Eye Health webinar series hosted by Women in Ophthalmology, SEVA Foundation, and Orbis International, brought to you by CyberSight. It is my pleasure to introduce one of our co-moderators this evening, Dr. Erin Schreifer. Dr. Erin Schreifer is a clinical professor and endowed chair in ophthalmology at the University of Iowa. An oculofacial plastic and reconstructive surgeon, she is actively involved in clinical practice, teaching, research, and advocacy. Dr. Shriver chaired Women in Ophthalmology's Summer Symposium in 2013, has served on the board of directors since 2014, and is Women in Ophthalmology's immediate past president. She is also the immediate past president of her state ophthalmology society and is involved in many leadership roles within the American Society of Ophthalmic Plastic and Reconstructive Surgery, including serving as their sole delegate to the American Medical Association. Welcome, Dr. Schreiber. Thank you.
Thanks so much for having me. Good evening, good morning, good afternoon. I hope you're enjoying whatever time of day it is in your part of the world. Thank you so much for joining us. This is an inaugural webinar series between Orbis, SEVA, and Women in Ophthalmology, and we're so excited to be here. We have it's a four-part series of women leaders in eye health, and it's really taken about a year of collaboration to get to where we are today. So we're really excited to be here with you. We're going to be talking about the challenges and opportunities that are really unique for women, both in terms of visual health and in terms of the professional environment for women in eye health care. And before we get started, I just wanted to take a quick minute to thank all the people who were involved in planning this series. Dr. Sarah Wester, Lisa Nijim, and I represented Women in Ophthalmology on the committee. Heidi Chase from SEVA was instrumental in particularly in getting the multimedia aspects of the webinar series together. And then Claire Sazali Timbo, as well as Gabby Kubayas, and then also the CyberSight team. Claire is really, she's our fearless leader, so thank you very much. We wouldn't be here today without her, so thank you, Claire. I wanted to just give you a little bit of an overview of what we're going to talk about today. Our topic is Eyeing the Gap, Gender Inequities in Visual Health and the Workforce. And we're really going to be talking about what leaders throughout the world, both women ophthalmologists and then women in visual health, and they bring their unique perspectives and issues related to gender disparities. We're going to break the session up into two parts. The first part is gender inequities in visual health and blindness. And we're going to be talking about highlighting the realities of gender inequities and then talking about how do we tackle these globally as a community and then as physicians. This session will be moderated by Dr. Imane Tarib, and we have three esteemed speakers. Dr. Tarib is from the United States, Dr. Swati Tomer from India, Dr. Helen Danesh-Meyer from New Zealand, and then Ms. Elizabeth Kishiki from Tanzania. Our second part of this webinar is on gender bias in the workplace. We're going to be addressing what are the issues, how do we tackle them, how do we address gender bias in the workplace with various levels of support, and then what are the mechanisms which we can do to support those who are experiencing it within the workplace. I'll be moderating this session, and we have Dr. Tanya Trinh from Australia, Dr. Binita Sharma from Nepal, and Dr. Greene also from Australia speaking with us today. It is my distinct pleasure to introduce my co-moderator, Dr. Imane Tarib. She's originally from Morocco and is currently based in Ohio within the United States. She's the founder of the Young Ophthalmologists of Morocco, co-founder of Women in Ophthalmology Arabia. She's on the YO committee of the Global Education and Research Society of Ophthalmology, and she's the media partner leader for Africa, a media platform for eye care professionals in Africa. I have met Dr. Tarib on numerous occasions at meetings throughout the world, and I always feel invigorated and energized when I talk to her. She's a powerhouse, she's a leader. Even as a resident, we knew she was one of the superstars in our field. And so when I thought about who I wanted to moderate this session with, she immediately came to mind. So it's really a pleasure to be with you here today, Dr. Tarib, and I'll turn it over to you.
Thank you so much, Dr. Shriver, for the great introductions and the warm welcome. It is my absolute pleasure to be co-moderating this session with you today. And before we start, I would like to thank the audience that is joining us today. Please know that you can use the Q&A feature to ask questions throughout the session. This session is being recorded and will be made available on CyberSite to watch as desired later. And please help us by sharing your thoughts and opinions through the polls. So as we begin to focus on this first session about gender equity in visual health in your community, we thought of getting the input from the audience about a question that is, what are the main obstacles to gender equity in visual health in your community? Do you think it is access to care? Is it responsibilities in the home? Is it responsibilities outside the home? Or is it cultural bias? Please click all that apply. Great. So our session today is for the Eastern Hemisphere. And so the answers were 26% access to care, 63% responsibilities in the home, 33% responsibilities outside the home, and 48% cultural bias. And we have used the same question last week for the session that was for the Western Hemisphere. And we had somewhat of similar answers. We still had a majority for responsibilities in the home, followed by cultural bias, interesting, followed by access to care, 46%, then responsibilities outside the home. Thank you for sharing your answers with us. And now we're going to move on to our first speaker of the night or the day, depending on where you are, and that is Dr. Swati Tomer. Dr. Swati Tomer, it is my absolute pleasure to be introducing you today. Dr. Swati is the director and consultant of Swanitra Eye Hospital. She is the medical director of the Eye Bank Society of Rajasthan. She is a cornea, ocular surface, and refractive surgery specialist, a professor and head of the Cornea Service Department of Ophthalmology of NIMS University in Jaipur. She's the state head of Women Ophthalmologists Society in India, in which I had the honor of meeting her for the first time in 2019. She's also a member of the State Blindness Control Society and a member of Corneal Surgeons Task Force SightLife USA. Thank you so much for joining us, Dr. Tomar, today. Please go ahead.
Thank you, Imane, for this lovely introduction, and thank you, Erin, for having me here today. And when Erin asked me to talk about on this topic, I was really not. I was thinking that is this has a major change in our Southeast Asian population. And when I actually went through and read about all these the studies and the things, the articles that are available, I was myself very surprised. And I definitely thank Erin for getting me here today. And when we talk about this as a problem in South Asia, it is definitely a bigger problem than many of the problems that we are actually thinking and talking about. And while reading on this subject, I came across two very important surveys in India, because I could not get hold of many big surveys outside India or in the surrounding countries. And there were about 100,000 individuals that were examined in these two surveys, spanning over a period of 5 years. And the first survey took place in 1999, and the second was in 2006. So definitely here we see a change in healthcare facilities that have been made available in a span of 5 years. And the major drawback that I see here in the survey is that they looked at the population above 50 years. So here, when we talk about women and reaching healthcare services, to them, 50 years is a very long time, because a lot of them get blind at a very early age. And the visual acuity of 3/60 again is definitely too less to note. But then when we look at the survey here, we see that the prevalence of blindness in the male population was definitely lesser as compared to the female population in both the surveys. So this is something that we see that even after 5 years, the prevalence of blindness was much higher as compared to males in females. And when we go into the details of the survey and see what actually the females, why these females are less amenable to the healthcare facilities, it was seen that in urban areas, this difference was a little lesser as compared to the rural population. So here we have a rural population who has less access to the eye care. And again, if we adjust this for a place and age of the patient, again, the females, the prevalence of blindness in females is almost double. So here there's a cause of worry here, because see, almost as half of the females are going for an access to an healthcare facilities or getting their eyes treated. So what could be the reasons that we think about in this part of the world, and especially in India and surrounding countries, is the traditional eye remedies. Here we come across a lot of patients in our clinics who come with putting goat's milk in their eye, jaggery in the eye, oil in their eye, and for getting rid of various eye conditions or foreign bodies, they remove by the tongue. So these are certain. This is not thought of in the Western world, I think, but then in the traditional eye system, they definitely lead to a lot of corneal infections and other things that we see. The workplace injuries are very, very important, because as you see in rural areas, they're mostly farmers and they go to the jungles to and the cooking is again not on the gas, and they have this wooden fire that they collect wood every day. So they are more amenable to these workplace injuries. And the pharmacies and the informal drug sellers, I have to say that they're kind of they're over-the-counter drugs that are available, and most of the times when they reach us, they are on steroids for all the conditions. So probably we can think of that, steroids, they reduce the symptoms so initially, so it's easy to prescribe them steroids, and that leads to the problem. Here I have posted some of the pictures of my patients, and you would see what is common in these pictures is that they are usually blind by one eye. Either one eye is eviscerated, or they have an irreversible blindness or a corneal opacity here reality. So they're usually reporting late to us, almost when one eye is completely blind and the second eye starts giving problem, and that is when they come even for simple procedures like a cataract surgery, which is being done free of cost in both the urban and the rural areas. So this is a cause of worry, because they keep on working, they keep on doing their task with just the eye that they're seeing with, and sometimes they land up with one or no eye. So when we look at the factors, what is actually happening in Southeast Asian region as compared to the other regions is that the income, the poverty is very, very important to play a part in the blindness of the females, especially, and elderly females. Because here there are lots of things that we give to the patient, that you come, you would get food in the hospital, you would get medications free of cost in the hospital, and still they are so poor that they can't even travel to the nearest healthcare facility. And sometimes what I see, the trends that are happening is that the government has to send vehicles or ambulances to get these patients, and most of these elderly women, they do not come out of their house to get the treatment. Rural, again, the rural women are most affected, and we can see that a couple of my patients, they don't have money to pay. So what they do is that when they get treated, they pay in kind. They come back with a bottle of milk, the bottle of a bag full of vegetables, and that is how they come. And that's very heartening to see all these patients when they are not able to pay and they're paying in kind, and they're coming all the way traveling just to thank you for for the services that you do. Level of education, I feel, is the single most factor, and it is very important, and it has a lot of association also, because we usually see that these rural patients are not they are not educated. So and it starts right from the childhood. The girls are made to work in the farms, in the fields, or they're made to cook and help their mothers, and the boys are the ones who go out to earn with their fathers, and they actually get an access to school education also, because they feel that it's very important for the boy to read and write and to count money and to sign, and the females do not have an access to an education because so this starts very early in the life, and This is how they are usually unaware of the things. I always feel that there are lots of invisible gatekeepers, and one of them are a community called as men. I am not being feminist or anything like that, but I feel that most of the policy decisions that have been made or are being made are by men, and they somehow they are vulnerable to the female situations, or the female, they have an understanding of the whole thing, and they do understand the lack of facilities available for the females, but somehow they kind of have a blind eye for the inequity that we see amongst the females. So these decision makers are very, very important to play a part and to be more vulnerable to the female population, and more of the female population should be part of the policy decisions, because as we understand, we would understand a female problem much more in a better way as compared to the males. So when I was reading these articles, I came across a very nice program that has been started in Pakistan, a lady health worker program, where the society is very conservative and the penetration into the house and to talk to the female is almost impossible. So this is this lady health worker from the surrounding community who can talk to them, go inside the house, talk to them in the language of local dialect, and they can actually motivate them for taking the care or health care. So I would suggest that, as I said before, that it's very important to have these females or females at positions, or females who can influence, or females in the local community who can design and deliver the health services. And actually, we need to address the issues. The issues are many, and the issues are different everywhere. So I would say in India itself is a very vast country, and we have issues which are very different in the north of India as compared to south of India. So if we are talking about Southeast Asia, South Asian population, the issues are much, much more. So they have to be targeted interventions to all these problems. Like in some places, we have a pandemic of endemic fluorosis here. So the water, the fluoride content in the water is very high. So we need to target how and why we can help these women, and why are they not accessing the healthcare, and how what healthcare facilities that we can give to reduce the fluoride content and save them from children and women from getting blind later in their lives. And again, with the kind of the technology revolution, everybody has a cell phone, everybody has an access to an internet, and these days we are all getting virtually connected also because of unprecedented circumstances. So I would say that revolutionizing eye health care, and especially for women in remote areas who cannot report to us in the urban healthcare system, they should reach there to their household, to their rooms, where they can have a telekind medicine kind of a thing, which is available still, but not to that level. And I always feel that the universal health coverage is not universal without an eye care. And we'll see a lot of times the eye care is left behind in these immunization programs or healthcare programs. And the females again here play a very they are a workforce, and they play a very important role in reaching to these eye healthcare needs of women. So the females have to come out in the forefront in treating these patients. And I'm really thankful to IPB and SEWA. I went through this article, and I think I recommend that everybody should read this. It's a beautiful article and a survey that has been done by IPB and SEWA Canada, and they have come up with a global initiative for women. We also know that Orbis is very, very actively participating in India and surrounding countries, and we keep hearing about the good work that they do for the women in particular. And again, I'm very thankful to Women in Ophthalmology and Erin and everybody on the board for getting me here and having me here. Thank you so much.
Thank you so much, Dr. Tomar, for such an insightful presentation. This definitely was data heavy, and we thank you for giving us those numbers. And so while our second speaker, Prof. Danesh, is setting up her slides, allow me to ask you one question before we move on, Dr. Tomar, and that will be, what is in your view the strongest independent predictor of healthcare service utilization in women in South Asia?
I feel the literacy rate is the most common predictor, because I feel wherever the women are literate, and they understand the nuances of the eye health and why not seeking eye health would be deleterious to their profession and the whole family, in fact. So I feel very, very important is the literacy. The women should be literate enough to, understand what they are going through.
Yeah, absolutely. Awareness must be must have a great impact on them actually realizing that healthcare that they need is available out there. Thank you so much, Dr. Tomar, and we'll get back to you in the discussion. And right now, it is my absolute pleasure to introduce our second speaker, Professor Helen Danesh-Meyer from New Zealand. Thank you so much for joining us today. Professor Danesh is a professor of ophthalmology in Sir William and Lady Stevenson department in the University of Auckland. She is the head optic nerve and glaucoma research unit in the head of optic nerve and glaucoma research unit in New Zealand National Eye Center. She's the chair of Glaucoma New Zealand, the chair of RANZCO Women in Ophthalmology, and she is internationally recognized for her expertise in glaucoma and neuro-ophthalmology research and education. Thank you so much for the honor of joining us today, Professor Danesh. Please go ahead.
Thank you. Thank you for inviting me to participate in this exciting platform. I've been asked to speak about gender disparity in eye care over the next 5 minutes. And what I first realized when I was looking into this topic is that no matter what study we look at, we can see that women have a disproportionate share of blindness. Whatever country we look at, whatever different aspect we look at, women share that disproportionately. And it can range between 50 and 60%. The leading causes of blindness are refractive error, cataract, macular degeneration, glaucoma, and trachoma. And it will vary from country to country which one is the leading cause of blindness or visual impairment. But overall, the ratio between women to men is between 1.1 to 1.5. Another interesting finding was that over the last several decades, this has not changed dramatically, and this ratio has remained the same. So if we look international, we can see that the ratio of gender inequality has not changed. And we can see that whether it's in high-income countries, in our part of the world, in Australasia, or in Africa or the Middle East, the common theme is that women continue to have a greater responsibility and share of the blindness. Before I come to speak about Australia and New Zealand, I'd like to just canvass what I discovered from looking at studies throughout the world. So first of all, if we look at Egypt, we can see that blindness exceeded in women was greater than men. One area that was particularly interesting was that of cataract surgery and trachoma, where the rates where women experience these are about twice as much as men. We've already heard about some of the statistics in India and a very fascinating talk by Swati, who spoke about the challenges of providing healthcare for women. But even if we go to first world countries such as Sweden or developed countries, we can see that females generally have poor vision before they present for procedures such as cataract surgery, and even some more nuanced differences that they have longer waiting times before they undertake cataract surgery. I was asked then to explore what about the discrepancies in gender disparity in Australasia. And I think the most important insight that I had in my reading was the lack of evidence and the lack of studies that focused on this gender disparity. And I thought that was astounding. While they looked at many other factors and variables, the difference in gender disparity was mild and there was minimal studies. So what I'd like to share is the few studies that I managed to find today. So the first is if we looked at the prevalence and causes of blindness and low vision among adults in Fiji. And in Fiji, they found that being Indo-Fijian, female, and older were all risk factors for visual impairment. And you can see that the ratio for women was significantly greater than for men in all of the various categories when they looked at diabetic macular edema. Then we looked at other studies which looked at Australia and New Zealand, and we could see that trachoma, which is an important cause of blindness, again had a significantly higher rate of ratio among women, almost twice as high amongst Indigenous women in Australia. We looked at the diabetes and retinopathy in Pacific people in South Auckland and New Zealand. And again, we found that the ratio for women experiencing blindness from diabetes was significant. But in one study, they did show that Pacific men and those of Fijian ethnicity had higher rates of macular edema. And then when we looked further at outreach service programs, we can see that in general, there was less healthcare being able to be provided for women. So then we come to the question of why. Why is this an international observation? And why is there so little studies done on this? Well, I think the previous speaker spoke about some of the issues that we face when we're trying to deal with gender disparity in health outcomes. The first is access, that women have poorer access to healthcare services than men. And we see that they have lower rates of cataract surgery in low and middle income countries, even though they represent a larger part of the population. Interestingly, girls are less likely to be offered surgery for bilateral congenital cataracts, and that may reflect some of the values in various countries where these issues are present. But beyond access, I think we need to look at individual determinants of health, that perhaps there's a lack of social support and awareness of health programs, which mean that women do not have the ability to access the available healthcare available to them. If we look at broader social constructs, and I think this is what the previous speaker was speaking about, we can see that there are multiple frameworks in which we see that women are limited in all regards. Whether this is poor utilization of healthcare in general, social, cultural status of women means that they are often not in a position to prioritize their own health. Importantly is the economic decision-making, that in many countries, women do not have economic power and therefore cannot spend financial resources on their own health. Their work role, women are responsible for looking after the families and the children, and also for often working in the farms, and therefore they're not able to leave their responsibilities to look after their own health. Several studies highlighted the need for education and saying that as women became more educated, they were better able to address their health outcomes. So in summary, approximately 60% of the world's blindness and visual impairment occurs in women. The trends seen in both developed and developing nations. Importantly, studies that focus on gender are sparse, and this is one area that we need to address. Women in developed countries generally seek more healthcare, but still have poor outcomes. And the disparities arise from a range of influences that are both biological, behavioral, perceptual, cultural, and societal. So in terms of research, we need to focus research so we identify the causes of the gender disparity. We need to work on finding ways to access gender equality in the local and regional levels. And we need to further understand and determine barriers to health. So there are many different approaches to promote health education in a gender-sensitive fashion within the communities. And women representation in programs are crucial. And I think the previous speaker also highlighted this aspect, that in order for women to receive more resources, it is important to have women in power roles to help make the decisions for women. We need to recognize that in some areas, women do not have any decision-making powers. And I'd like to end with a quote that I think would be important for us to discuss if we have time. A gender equity approach recognizes that women and men have different needs, preferences, and interests, and that equality of outcomes may necessitate different treatments of men and women. This is because achieving a fair distribution of the resources and benefits of development may require different treatment of women and men, girls and boys, in a way that projects are delivered. With this in mind, targeting women purposely may be necessary to help them overcome barriers that specifically affect them. Thank you.
Thank you so much, Prof. Danesh-Meyer. This was definitely enlightening. I would like to thank you for the literature review. And before we move on to our following speaker, my question to you is, since you see that there is a place for more research regarding the difference in healthcare that is given to women, what do you think is the place of junior, let's say, residents or interns in ophthalmology while they're just starting their career and actually playing a role in producing more research in that regard?
I think that one thing that junior residents, and in fact we can all do, is try to set up systems that record information accurately. So a lot of the problem is the lack of data. And I think with junior residents, their ability to navigate the internet and different platforms better, they can start introducing platforms and ways to collect data so that we can better understand the extent of the problem and the nature of the problem as well. The second thing that junior doctors can do and junior ophthalmologists is to try to establish small programs that actually test different ways that we can actually improve women health for women. So there's no reason that junior doctors can't initiate research projects, and also to collaborate with more senior international groups such as Orbis and Women in Ophthalmology, and draw on resources so that they can actually introduce programs and research ideas that can bring out results. Because the more research we have in this area, the more we will able to clearly identify what the problem is, and then identify programs that can relate and address these problems.
Yeah, thank you so much. We're definitely lucky to have platforms such as Orbis, SIVA, and Women in Ophthalmology to kind of create that link between the practicing physicians and the real world where the problems are actually occurring. Thank you so much another time, Professor Helen. And we will move on now to our third speaker, Elizabeth Kishiki. If you can please start sharing your slides. Thank you so much. It is my absolute pleasure to introduce our third and last speaker for this first session. It is my pleasure to have Ms. Elizabeth Kishiki with us today. Thank you. Ms. Kishiki is Childhood Blindness and Low Vision Coordinator in Kilimanjaro Center for Community Ophthalmology. She assisted with the development of national pediatric eye care plans in the region. She helped establish child eye health tertiary facilities in 6 countries throughout Africa. She is the advisor for SIVA Foundation and Light for the World International. She's also an author of numerous research publications and in child eye health care manuals. She's the co-chair of Gender Equity Work Group in International Agency for the Prevention of Blindness, IIPB. It is our absolute pleasure to have you with us today. Please go ahead.
Okay, thank you. I've been asked to present on gender equities in visual health and blindness. And when I was thinking about this topic, I had some questions to ask myself, and I thought the questions are very practical for everybody who is dealing with this kind of topic. And since this problem has been there, and we have seen the other 2 presenters have mentioned the same experience. So what is it that is missing that we need to know about gender inequities, and what can be done to like close the gap or do away with these inequities? One of the main questions I was asking myself is that what are the barriers that limit the use of services among both men and women, and what strategies that have been tested and found successful in achieving the gender equity. And when I was looking at the differences in burden of blindness in the total population and looking at different studies, I fell under one of the the reference, and which was done by our group, and even the AAPB in the Atlas has the same figure, and that is women are still contributing to the greater chunk of diseases. Like 55% of women are blind. 55% of the group of blindness are women. And men are just contributing to the rest, that is 45%. And looking at the different surveys that were done across the globe, you see the age-adjusted odds of blindness in women compared to men. Still, Africa, Asia, and industrialized countries, women are still leading in blindness. And what are the reasons for gender disparities in blindness prevalence? We all know women live longer than men. We know that they bear risk of acquiring eye diseases. We know that there is unequal utilization of eye care services among women, and there are some other reasons that contribute to women not accessing eye care services. The barriers to use of eye care services are different from men and women. Looking at the cost, who controls the decision-making at the family level are men. So they are the ones to decide who goes to hospital, who wait. The distance to the services. Many women have no ability to travel and receiving the services. And you see, and you will see that some of the women are too old, they can't just travel alone to the services. And this is the true experience from our part, that Africa, many of the eye care services are provided in urban areas. In rural areas, people have to travel to these urban centers to access services, or maybe they go for mobile clinics if they are there in their areas. From my experience working with this organization, I have seen a lot of women traveling from different corners of the country, coming to towns like Kilimanjaro, Dar es Salaam, or even in other countries where we work. We see many men traveling to these big cities, and very few women are not there. But when you do outreach, you see them coming to these clinics, because now the services have been like brought closer to them. They come to access services, but then accepting the services is another thing. But at least when the services are being brought to them, they can access. Again, another barrier is knowledge of eye conditions and services. So we are talking of literacy. The level of literacy among women in women category is higher than the men. The men has more the men group has more information about where to get the services, maybe how much it costs. They can access the service, the information easily. But for women, many of them do not know exactly what is going to happen. So literacy contributes to their barrier to accessing the services. Another barrier, like the low perceived value of fear of being a burden to others. Many women, because they can't like access the economy, their economy is lower. They can't decide on their own. They depend on their men. So sometimes the reporting that they can't see it's like they don't want to be seen as a burden to the family. So they just keep quiet. But again, it's fear. What if I go to surgery and I go blind totally? For example, if a woman has been identified with a cataract and they can see a little bit. So they are afraid maybe if I go for surgery, this is going to be even worse. So they opt to keep quiet. And again, it's like, if I go blind, who is going to take care of my children? If I go to town for services, who is going to take care of the remaining siblings? Like, there is a lot of questions that hinder them not to seek healthcare services, especially eye care services. So they tend to like stay untreated, just like that. And the fear of outcome, they don't know, like these new technologies, the IOL implantation, sometimes they tell themselves, they hear says that if you go for surgery, they remove your eye, they put goat eye or cat eye or maybe something else, but like they don't know exactly what is going to take place in the healthcare system. And sometimes they don't trust the healthcare system. They are comparing with other diseases, but that is not the case if they would have like find or try to find the proper information that would help them to seek for service. In my 15 experience with working in the field, we tried to test these strategies, and we have written a lot about these strategies, and we have read a lot of literature that also suggests some of these strategies really work. The use of community informants as part of outreach helps more women to know where the services are, to know where they can get the eye care services, and supporting the women to reach to the service stations is very important. So provision of transport to hospital. Whenever there is an outreach, whoever has been identified with eye disease that need further management, if they could be provided with transport, it makes them receive instant eye healthcare services at par. Counseling of family members, this is very, very important part of it, because since they are not the final decision makers in their family, they need to be counseled, and men need to be involved in this process. Even the family members or maybe the children need to be involved in the process for the women to accept the eye care services. Again, the women to women contact is also very important, because it tends to be like they trust each other. Women trust each other. So you'll find that we have these sentinels that is being supported by Shriver. They are trained to identify eye disease among their fellow women, and it turns very positive that they are trusting these sentinels, and more women are being seen seeking and receiving eye care services. And the use of case finders, community case finders. This is a combination of both men and women to go around the community and find different cases. So you'll find that the sentinels would identify their fellow women, and their fellow women receive the eye care services. And whenever they reach at the hospital and find it's a female ophthalmologist, it brings more freedom for them to, like, they can ask questions freely, they can access services easily. And since you provided transport after surgery, they go back home, they are sure that there is transport to take me back home. And that also contributes to more women receiving eye care services. As a conclusion, I find that gender inequities around the visual impairment and blindness is a complex issue. Society challenge, but not an it is not like something that you can do it separately. It has a combination of a lot of things. It has its roots somewhere. So when we are dealing with the gender inequalities, we have to look at all the other issues that contribute to this problem. So it requires an embedding like gender in all eye health programs from onset, from the data collection, from the analysis and dissemination, and even the implementation of the findings, because we are doing a lot of work, reading, doing research on gender issues. But then what are we doing with those findings? We need also some strategies to make good use of the finding. And even some of the programs, I know there's a lot of programs doing eye care services, but those best practice are not well documented in some of the programs. So we are missing some of the information so that everybody can like access and implement the good practice that has yield positive impact in their community. Thank you.
Thank you so much, Mrs. Kishiki. This was a great presentation. And first of all, congratulations on the amazing work that you are doing in Africa. You mentioned in your strategy that counseling is really important. Why do you think that is such an important thing when building a strategy to address gender bias?
Yeah, counseling is very important because as I have mentioned, there is a lot of barriers that hinder women to access services, but some of the barriers just need to we need to eradicate fears among them. We need to help the community understand that even women need these services. For example, I mentioned about men being involved in counseling process. So if we don't involve women, I mean, if we don't involve men who decide on women's behalf, that means these women will not get the services. Again, women feel shame to be like a burden to the family. So they need to be counseled that it is okay because you have acquired a disease. Because of your age, you become blind, but that blindness can be treated. Don't feel shame. You need proper information. These women need proper information for them to decide. Sometimes it is within them that need to be like that. The fear of unknown need to be removed through counseling. Again, for women, majority of them, when you speak to them, why didn't you seek services? They were like, if my man goes blind, I think I will fight for him to see because he is the man. He needs to see to make sure that he provides for the family. So counseling would help these kind of women to understand the need of eye care services as soon as possible. And the women are less likely to ask you for family support compared to men. So when you are doing family counseling, you automatically help these women to receive these services. Thank you.
Yes, it definitely has a lot to do with the family structures of the community.
Yeah.
Thank you so much for your talk. And before we go to the discussion, we have another poll question for the audience that's joining us today or tonight, depending on where you are. And the question this time is, how should our organizations channel our efforts to increase gender equity in visual health? Click all that applies. Increase awareness of the issue, conduct research to better document the disparities, train local female advocates within eye care teams, encourage infrastructure changes, transportation, dependent care, etc., to support women. And the last one, encourage outreach clinics to specifically target women patients. You'll have few seconds to click on all that applies to you before we move on to the results. A couple more seconds before we close the poll, and here we go. So we have a tie between increasing awareness of the issue and encouraging infrastructure changes, transportation, dependent care to support women, with 65% answering those, followed by another tie between conduct research to better document the disparities, as well as encourage outreach clinics to specifically target women patients. Another 62%, and the last one is train local female advocates within eye care teams, with a 58% of people answering to that one. And just to compare to the answers that we had last week again, there's quite a big similarity, and it was first increase awareness of the issue, followed by encouraging infrastructure changes to support women, followed by training local female advocates within eye care teams, and conduct research to better document the disparities, as well as encouraging outreach clinics to specifically target women patients. It seems like the percentages all go in the same direction with a tiny little bit of differences. So thank you all for submitting your answers. And the quote that Professor Helen Danish mentioned at the end of her presentation really stuck to me. And I would like to go back to that, Professor, and ask you, how do you think we can implement that different approach in healthcare that depends on on gender? How do you think, practically speaking, that would be applicable within our practice?
You know, listening to the other speakers, I was actually struck that in the second question, all those choices really need to be taken simultaneously in order to achieve that. And I think that's what is I extracted from this quote and from listening to the speakers as well. For example, the outreach programs, they will help make an immediate difference, while training female ophthalmologists and changing the structure, that's more of a long-term plan. And education is an enduring one, which will build on each other. So I don't think we can actually make any of those changes independently. We need to do them all. And we need to have research, we need to do them all. But I think that, listen, I was struck by the differences in women's approach, especially in the last speaker when she was speaking about Africa, that they would want the men to see first because they're the carer in the family. So I think a lot of it goes down back to changing the way women value themselves in society. Absolutely. And that may start with educating children and young women and go back to that very core of valuing their contribution to the community and to society. So I think that we need to do all of those things, but I do think that needs to be treated, women and men need to be treated differently, and we need to understand how we need to approach women and address their issues specific to their area, which both the speakers from India and Africa were highlighted for me and that I didn't realize before.
Yeah, absolutely. And I think that just talking about the fact that there might be a possibility to approach healthcare differently between genders is already a first really good step to getting there eventually. We still have a minute of discussion, and I would like to go back to Dr. Tomar with one question from the audience, and that was, is being a woman disadvantages considering other eye diseases, or is it a big difference in only blindness?
No, I think it's not only blindness. It's when we look at the South Asian thing, it is the all healthcare that is, and in fact, blindness comes together with all the healthcare. When you're approaching a home in the rural area, you just don't see the nutritional status. You obviously see how they are, are they any blind or anything. So it's just a amalgamation of everything together. And I think everything should be looked at in a view. The only thing I wanted to say was that the eye care is usually neglected. So when we are looking about the anemia and the immunization and which is suffering, so eye healthcare comes the last. So this is what is to be looked into, and eye healthcare should be a priority, I think, as compared to this. And I see that lagging in many of the policy and programs in India and surrounding areas. So this is something to look at. And women, I'm really, I think Dr. Helen pointed out that women have to stand up for themselves. We just have to understand that we are equally important as men, and we need to have the eye care or any health facility as much as the other men would, or anybody in the family would be. So that's a very important point that we should remember always, that we should stand up for our health.
Absolutely, Dr. Tomar. And I really believe, I truly believe to my core that organizations such as Women in Ophthalmology, Women Ophthalmologists in India, or any other place in the world are a great place to start that conversation to eventually have that impact that we all want. Thank you all so much for such a stimulation discussion, for wonderful presentation and insightful data that you have presented to us tonight. And I will like to invite everyone to move on to the second session. And with that, I'll give it back to Dr. Erin Schreifer.
Thank you. What a great session. I'm glad it's recorded, so many of us can watch it again, or we can get our colleagues and friends to watch it, or our trainees. So thank you all to our experts for speaking, and Dr. Tarib for moderating this session. We're now going to move on, and we're going to start this second section about gender bias in the workplace by asking a question. So we're going to start with another poll. We'd like to ask you, what area do you feel is most affected by gender bias at the workplace? Is it career advancement and promotion, financial compensation, surgical time and learning, or academic involvement? Great. So as you can see here, career advancement and promotion was 62% of the respondents felt that career advancement and promotion were the biggest area, the biggest issues in terms of being affected by gender bias in the workplace. And then the others were pretty similar. Surgical time and learning and academic involvement were 14%, and financial compensation was 10%. So if we look at what we had from last week, the Western Hemisphere webinar, we thought it would be, again, worthwhile to kind of see what we received then. And you can see there, they also felt the same way, that career advancement and promotion really was the biggest issue at over half, with 53%. And then academic involvement was next with almost a quarter, followed by surgical time and learning and financial compensation. I think we should do something with this data, maybe just use it to spread awareness. We've talked to Orbis and Seva about getting this information out, because I think we're learning here what really are the issues for many of these women ophthalmologists. It's my pleasure to then introduce our next speaker. This is Dr. Tanya Trinh, and she is a staff specialist in cornea, external disease, and refractive surgery at the Sydney Eye Hospital in Australia. She recently returned home to Australia after completing her clinical and research fellowship at the University of Toronto in Canada. And I understand she's still running grand rounds with the University of Toronto. She's actively involved in advocacy, teaching, research, and she's received numerous awards for her efforts. She currently serves on RANSCO's Women in Ophthalmology Executive Committee and is the secretary for the Global Research and Education Society of Ophthalmology. Dr. Trinh recently received international acclaim for her Toronto Eye Review TED-style talk, and it was entitled Unconscious Gender Bias and Its Impact on the Imposter Syndrome in Women. If you haven't seen it, you've got to check it out. You can just search Dr. Tanya Trinh, YouTube, or Imposter Syndrome, and it will show up. She's become kind of a social media celebrity, and we're really excited to have her here today. Right after I heard her talk, I sent it to Claire and said, let's see if we can get her. I think she's perfect for this session. The video goes over a lot of overview of gender bias in the workplace, and then she tells her own story of imposter syndrome. So Dr. Trinh, I'm going to turn it over to you. Thank you for being here.
Thank you for the very kind introduction. And at this point in time, I thought I would give a little bit of an introduction about a talk that I released, as Dr. Shriver had just introduced, about unconscious gender bias and its impact on imposter syndrome in women. And I want to focus really on the unconscious gender bias and its impact. And there was a specific reason why I named my talk in this way. I thought I would hark back. I've now spent about 9 or 10 weeks as my first foray into the world of being a specialist after finishing my training. And I thought I would share some of my experiences because it's become quite aware to me that once you have learned about these things, it's difficult to unsee them. And so one of my very first private cataract patient that I had booked was a male radiologist. And after I had taken him through, and this was maybe my second day of work, after I'd taken him through the history and the examination, and we talked about what kind of lenses he might want, the pros and cons of surgery, the surgical procedure, and the post-operative care, as he was leaving the room after signing his consent form, he said to me, "So, how many cases really has the surgeon done?" And I was really taken aback because in my mind, I was like, I'm not really sure who you thought you were talking to the entire time. But I just assured him that, as your surgeon, I can assure you that I have the requisite qualifications. The second experience, also in that short period of time, was my first public hospital operating list, where, it's routine that you come in and introduce yourself. But before I had the chance to say anything, I was told to write your name up on the board, please, thinking that I was a medical student entering the room. And so dutifully, I went over to the board and wrote my name up next to surgeon. But it's just those cognitive biases that you realize that you just have to work that little bit harder to gain that credibility with in a new environment. My fourth week operating, and I kid you not, we were literally after lens disassembly and inserting the intraocular lens, my patient, and granted under a little bit of sedation, asked me, is it a woman doing the surgery? And at the time, I just didn't really know what else to say, but wonders will never cease. So these are just really examples of unconscious gender bias that we currently swim in within this environment. And the point of the talk was reframing about how we think about imposter syndrome. And if I go through a brief definition of this, is that imposter phenomenon is a psychological pattern in which someone disregards, their skills, talents, accomplishments, even in the face of accolades and prizes or titles that would tell you otherwise. And they harbor this persistent internalized fear of being found out as a fraud or that they don't belong there. But the problem with imposter phenomenon, and, it really reflects where everyone is, most people will identify with this, but it's really thinking about the paradigms which led to these internalizations. The problem with imposter phenomenon is that it's not the individual, but the system, really, that, it places the focus on. So it blames the individual, and by doing so, it creates it as if it's a women's issue and therefore a woman's job to fix. So you're pitching the individual against the system. And what it really should be is it should change and switch the focus and the emphasis and the reparative efforts to changing the inherent bias within the systems. And this makes it everyone's responsibility and everyone's priority. So if we look at a couple of examples, and I'm going to try and rehash my talk in the remaining few minutes we have, but if we look at the evidence behind, and really this was the gist of my talk, is to provide evidence-based examples that people could not refute, to look at examples of gender bias within these places that we work. And when we looked at letters of references in 2009, there was a study where two researchers looked at over 300 letters of male and female applicants for a medical school application, and found that there were systematic differences in the way that their supervisors would write these letters. That letters for men were 16% longer than they were for women, that they were 2.5 times more likely to make a ringing endorsement like, he's the man, he's really the one that you want, he's the man for the job. And they were 7 times more likely to include disparaging comments about personality for women, or use grindstone adjectives. So instead of saying, she's really the best for the job, they'd say, she's a hard worker, or she gets the job done. But it wasn't really, those ringing endorsements that came in. And you'd think that maybe, you know, it's 10 years ago, it's an older study, but if we fast forward a decade later, we find that this still happened. So the gender-based differences are still being detected in letters of recommendation. And it's important to remember that we as supervisors don't intentionally go in writing letters differently for males and females. It is those inherent biases that we exhibit that actually get through into the way that we express ourselves in a letter of recommendation. So now we're looking at the other side. If we're looking at the judgment of, say, a CV that comes across for a selection for X, Y, or Z. And, you know, one of the more famous examples is the two Swedish immunologists, Wenneris and Wald, who took, you know, a really critical look at the Swedish Medical Council's review policies. At this time, they noticed that women were achieving more completed PhDs, but being less than half as successful as their male counterparts in being, you know, selected for a postdoctoral fellowship. And they tried to initially have a look at this, but the Swedish Medical Council were so convinced that their processes were gender blind that it took 2 years and a court order for the researchers to gain access to this information. And what they found shocked the inherently, you know, male or overwhelmingly male selection committee. And they found that women not only had to be better than men, but they had to be 2.5 times more productive than men to achieve the same score in terms of competence. And if we put that into realistic, you know, time or effort sort of blocks, that represents about 3 extra papers in Nature and Science with impact factors of now 41 and 42, or 20 extra papers in a journal with an impact factor of 3, just to achieve the same amount, you know, score. And if you think about the amount of work that goes into one paper to get into Nature or Science, it's, you know, most people would say probably at least an average of 3 years. That's nearly a decade's worth of a woman's time just to be considered an equal applicant. But it flows into the day-to-day as well. So if we look at the use of professional titles, you know, at the Journal of Oncology a couple of years ago looked at unconscious gender bias and found that there was a significant proportion of women who were introduced by their first name rather than their professional titles, and the opposite when it came for men. And in an evaluation of general medicine grand rounds at another center in, you know, published in the Journal of Women's Health, they found that if there was a female introducer introducing a male speaker, then they were 95%, when there was the female introducer and a male speaker, formal titles were used 95% of the time. But when we switched this and we had a male introducing a female speaker, the professional title was then used 49% of the time. And that's not just on the podiums and when you're up in front of a microphone. It filters down to the way you introduce your colleagues, your fellows, your registrars, and your residents to your patients. It's the way that our nurses and technicians might introduce a female doctor when they come in. It's the way that you address someone in the tea room, you know, Dr. such and such compared to Claire or Anne or Susie. You know, it's just making sure that we are being conscious of the way that we introduce and address our female colleagues and professional individuals. So just to summarize in terms of mechanisms for real change, it's important to acknowledge and evaluate your bias. And by that, I mean systematically looking at gathering data and critically evaluating how much we do or don't exhibit gender bias in a particular task. It's about changing the way we speak about women, so talking about their achievements rather than their physical or personal attributes. It's about thinking about attaching CPD to diversity and bias training. And I will put a caveat to this, is that there is some literature to suggest that occasionally diversity training can actually work against us with particular genders. It can actually lead to less women being included in some selection processes. It's really important also to involve men in our conversation. So, you know, thinking about whether our women's committees for X, Y, and Z should have some male representation, because, you know, a lot of the time when we talk and we bond with other women, that is fantastic and that is great. And that is really important for empowering junior women to speak up and feel heard in an environment. But we must also recognize that it can become a little bit of an echo chamber where you're just reinforcing what you're feeling, but the message and the real change is really getting that message out there and involving that other 50%. It's about active mentoring, and I'll expand a bit upon that in a second, but it's also about calling things out and realizing that your silence is a privilege. And if we break down feminism into the various, intersectional components, it's realizing that not just speaking up for your own area of being a feminist, but also being mindful that there are, other areas in which you are privileged that others may not be, and being sensitive and calling that out. We also need to look at data-driven, applying data-driven standards of equality into the system to prevent, gender bias. And that's looking at policies around parental leave, parental pay. We have a little bit of a furor going on at the moment about the way that parental leave in Australia is tied to female income rather than to male income. And it's also about, and this harks back to mentoring actively, nominating actively and with intention about the various panels you might put together for a particular event, or a person you might nominate for a particular position. It's really about taking that extra step to think about your usual suspects, and then just taking that extra moment to think, who else would I not normally consider, or who's not normally put forward, that actually does have the credentials to equally be on this position, is really important. So thank you very much to Professor Schreifer for giving an introduction to the talk, but it is here if you'd like to have a look at it. I've just tried to condense a lot of information into a very short speech, and would love to have that discussion with you. So thank you so much.
Thank you, Dr. Trinh. I'm really glad you were able to share some of those pearls from your talk. And you've taken a topic that I'm really glad you're shedding light on imposter syndrome and talking about the biases and spreading the word through social media as well. So thank you so much for that. While we're switching screen share for our next speaker, I just wanted to briefly ask you, how would you advise someone to intervene when they witness gender disparity at work? So now that they're aware to look for it, based on everything we've been saying, how would you advise them?
Look, it's a great question, and thank you for picking that one. I think it's important to be kind and to have a little bit of grace about it as well, and realize that you're trying to build a connection and share that understanding rather than coming at it from an adversarial type of thing. So it can start with things like, as I said before, nominating women. So if you notice, the easy one would be if there's a panel or a panel made of men, that we, just take a moment to say, it just takes something very simple, a simple sentence to say, great work putting the panel together. I just noticed that there wasn't a lot of diversity. I was wondering if we could think about, some of the names we might be able to even this up a bit. It doesn't have to be, coming on this feminist, train of rage and anger. It doesn't need to be like that. It just needs to be quite direct, simple, and proves the point. But it also goes with sexist comments. Like, if you catch, a senior making a sexist comment, and I hark back towards an example that I heard recently where someone was, a group was looking at maternity leave policies, and the joke was made by a male member that, women should just stop having babies, really. And the female came by and just said, well, we should just, I guess on that vote, we should just stop hiring women altogether. And it was said very sarcastically, but also in, it just used humor to diffuse the situation. But it also proved a point that the comment was inherently sexist, and, it didn't cast direct blame, but it just made people realize that really those sorts of jokes and those sorts of comments really aren't all that acceptable, and never were really. And also realizing that, part of my talk was centered on doing internal work to realize our own unconscious bias, but looking at those systems in which we can design, bias out of the system altogether. So little things like the data that shows that when you put together a selection criteria for an applicant and they're writing, this is my name and I'm a woman or a female, it actually, institutes some self-stereotypical bias into that. And so just by simply moving the male-female tick box to the end of the application actually makes a difference to the type of information that your candidates will put in, because they're not thinking from, I've just literally declared that I was a female or a male. And these subtle things that you don't think make a huge difference are really really important in terms of, building these design factors.
Great.
So,
well, thank you so much. Very much appreciate it. We're going to turn now to our next speaker. This is Dr. Binita Sharma. She's a cornea specialist and the chief medical director at Kirtipur Eye Hospital in Nepal. Dr. Sharma is an educator and a researcher. She previously taught undergraduate medical students, and she currently serves on the editorial board of the Nepalese Journal of Ophthalmology. She has a special interest in community ophthalmology and is SEVA Foundation's clinical advisor for programs in Nepal. She's been incredibly impactful to SEVA, and in fact, they said that she has been really instrumental in their mission in Nepal, and so we're very excited to have her here today to speak about gender bias in the workplace. Dr. Sharma, thank you.
Thank you, Dr. Shriver. I'm very, very glad to be here and in this distinguished platform. And after following Dr. Tanya's presentation, I think what I have to say is going to echo, it's going to resonate what she has already shared here. Give me a moment. We're going to talk about workplace gender bias. This is a topic which is not very commonly discussed in my part of the world, but it definitely does exist here. So let me start with this riddle. This is a riddle that most of us are very familiar with, where the son is, there is this child who is injured in an accident. In the operating room, the surgeon looks at the boy. At the scene of the accident, the father of the son is already dead. And the surgeon says that I cannot operate on this boy, he's my son, and how can this be? Studies which have been done in different settings have shown us that almost 40 to 75% of people take an approximate of 3 minutes to answer this riddle. And I take that very personally because it indicates that leadership in the field of medical science, female leadership in the field of medical science is still not easily expected or even accepted. So I represent here the 46% of total ophthalmologists in Nepal, and I'm here to tell a story. When I say I am the 175 female ophthalmologists working in my country. When I saw this number, the number was equally significantly proportioned when I entered into the field of ophthalmology. And I chose this profession, this ophthalmology, as my choice of profession with pride. But the pride was undermined immediately by the social bias, the social construct that we have. People told me that, oh, that's good. You have chosen ophthalmology. It's going to give you more time for your family. You chose it as an easy way out. It doesn't have a lot of academic requirement compared to other different fraternities. So you won't have to work so much and you can lead an easy and even glamorous life. So before I actually entered into the workplace gender bias, I was undermined by the social and the educational bias that exists in my part of the world. People even told me in so many ways that because I had entered into ophthalmology, I was okay for the value of money. If I had gone into some other fraternity, I would not be giving back the value of money. So that is the very first hurdle. And after having skipped over that, I went into that. And let me fast forward to my residency period. I had shouldered the responsibility as much as any other male resident. But when my pregnant belly started to show up, I was met with many appalled glances. People said again in glances and in words that, oh, what are you doing? Why have you done this? You have wasted away an opportunity which could have been given to a more deserving candidate. This indicated that nobody expected me to take up my responsibilities as they are doing, as any male counterpart is doing. But what did I do? I kept up with my responsibilities. I did not expect and I did not ask for any undue advantages. When I was carrying a baby inside or carrying a life inside me, I was deemed to be unproductive. But at the end of the period, I brought forth a beautiful life in this world and a competent ophthalmologist. What I learned from this point in time was that I learned to manage my time. I learned time management in a beautiful way. After that, during the training course, the next aspect where I was a little difficult to handle was when it was a access to the wet lab. In most of the countries in my part of the world, the wet lab itself are hard to find, few and far in between. And to have access to it in between, when we are working with many residents, it's very difficult. And being a female here did not help us very much, because I was met even with the words which said that, why are you trying to get practical knowledge? After all, you're not going to actually work. You are here only to get a degree. So whatever limited amount of access I had, it taught me various different things. I learned to multitask. I learned to do my work quickly. I became a fast learner. I learned to negotiate. I learned the art of logical thinking. Fast forward from that, from the residency training to once again when I started to work. When I was looking for work, what I saw was I went for interviews, and most of the organizations, they wanted a male face to represent their organization. The female faces were usually reserved for the front desk workers, where they would be nicely talking to other people, to the clients, and not particularly in a decision-making role. So in that kind of a workstation, in that kind of workplace, when I joined the work on a little remote part of the country, not in the city center, I was allotted a OPD room, a consultation room, which was well away from patients' waiting lounge, which could not be seen easily by the patients, a back room. The organization, the managerial aspect, they thought that if we have a female face in a decision-making place, that is not going to be very attractive to the patients. That was what the unconscious bias, it worked over there. And in the back room, needless to say, the equipments and the instruments that I had to work with were not very good. There were defective slit lamps. And with the less number of patients that I had to work with and defective equipments, the performance evaluation was not going to go very high. That was for sure. And what it taught me was to be a more meticulous examiner. And as I had to work with less number of patients, I became a more effective communicator. Not only within the hospital premises, I had to fight my way sometimes when the hospital had various kinds of outreach activities, where we had to go to remote areas for surgeries, for screening camps. Once again, the unconscious bias it seeped in, and it said that no, you're not likely to go there, you're not able to work there. There are very limited facilities that it's going to be very difficult for you. And sometimes when I was there, I even had the misfortune, or I even had the chance to correct one of the staff of the medical field, medical staff in that area, who was continuously calling a male non-medical person as doctor and completely ignoring me. When I corrected the mistake, the team at that place were very disappointed, and they said, they sent a woman. How can this be? So with all of this kind of evaluation that we had, and when this kind of feedback came back to the managerial aspect, the managerial part of the whole organization would stop me from going to outreach activities. And this directly reduced my exposure, directly reduced my experience, not to say reduced the financial advancement that I would be receiving from working in outreach clinics. But all of this done, I am working with a group of females who are doing excellent job in this part of my country, in this part of the world. When you look into the ophthalmology units of different hospitals, when you look into eye hospital, you'll see females working with patients. But in spite of having said that, we're still dealing with the bias that we cannot be in the leadership role, we cannot be in the decision-making position. Just like Dr. Tanya just said, who is going to operate on my eye? The patient asks, who is going to operate on my eye? We still have to face that every day of the week. But now I work with colleagues, my female colleagues who are heading eye hospitals, who are heading medical colleges, who are taking part in various important roles in developing the field of ophthalmology in my country. Now whenever I sit in my consultation room, I usually see a patient who comes in. When he looks at a person, a female sitting at the slit lamp, falters, asks me, is this the place where I get an eye exam? And I said, yes. And so, sister, where is the doctor? Sister is the term that is used in my part of the world for a nurse. And also, incidentally, in Nepal, it means a female sibling. So I take that word as a compliment. And I said, trust me, I am a doctor. Please come in, sit down. And how can I help you today? So this is my story. And this story is not going to end here. This is going to continue with a newer generation. And my hope is that every new generation, this story will have less of the bias and more of the achievements. And that is how we are going to work with reducing the gender bias and improving the whole fraternity. Thank you.
Thank you, Dr. Sharma. That's wonderful. Thank you for sharing your story with us. And really, it's really inspiring. I wanted to ask you, while we're switching the screen share, I wanted to ask you, if you were the manager or you were the leader in the organization, how would you create an equally gender biased, family friendly workplace? What would you do to set the tone, and what kind of policies would you implement?
When we start working in the hospital, first thing we have to remember is that it starts from the social construct. We cannot just change everything at the hospital level. The whole social construct has a stereotype. It's inculcated for like ages there. We cannot change the stereotype again. So the first thing we have to do, I believe, is that we have to try to change the response to that stereotype. And that can come from the family, that come from the school, that should come from the school textbooks, which have still the doctor is only a male figure, and the pictures show only a male figure, and the nurses are only the female figures, and the only person who's cooking is a female, and the person who's reading the newspaper at home is the male figure. That is the first stereotype that we have to change. The response has to change. And in the hospital area, in the workspace, the most important change in our response is that we have to stop making the male and the female workplace competition. There is no competition, there is no comparison. There should not be a comparison between how a male worker is performing and how a female worker is performing, because there are different ways of performing. We females, we work in a different way. We are more participative. We are less directive. And so if we understand this kind of concept and reduce the sense of competition within the hospital area, within our workspace, where male versus female is completely removed, and we can only talk about competence level, then we can go forward to make it more friendly for both the sexes, both the genders, without making it an issue on how or who is going to be a better leader or why a person is going to be a better leader. It should start with a small step. It should start from the families, from the social construct itself.
Well, thank you very much. I look forward to our discussion at the end of these talks. So thank you for your expertise and your time. It's my pleasure to introduce our next speaker, Dr. Catherine Greene. She's a true leader and an advocate in ophthalmology, and she's a champion for diversity and inclusion. She's head of the glaucoma unit at the Royal Victorian Eye and Ear Hospital in Australia, and she's an associate professor of health professions education in Monash University. She's had numerous leadership roles in various organizations. She serves as director with the Center for Eye Research in Australia, RANSCO, and ICO, the International Council of Ophthalmology. She's also been a council member with APAO and the APAO Women in Ophthalmology Committee. Dr. Greene, she leads the leadership development program, both within RANSCO and APAO, and she's been instrumental in their establishment. She's received numerous awards for her contributions, including the Officer of the Order in Australia. It was really an honor to actually give Dr. Greene the Women in Ophthalmology Champion for Change Award in 2019 at the World Ophthalmology Congress in Barcelona. I first met her at the Women in Ophthalmology meeting. We were just reminiscing today. It was in Virginia in the United States in 2014. And I was so impressed that she made the trip from Australia to come to the US for the Women in Ophthalmology meeting. Also, her comments were spot on, and you could tell that she was really an expert in the field of diversity and inclusion. She's been instrumental in really reshaping how organizations within her region and internationally think about the topic of gender equity. And so I was very excited when we had this session. I wrote her right away, can you make the date? Maybe we could change the date if you can't make it. So Dr. Greene, I'll turn it over to you, and thank you for being with us.
Thank you, Erin. I'm having trouble with my mouse. There we go. So welcome, everybody. I feel a huge privilege to be involved in this amazing initiative. I feel amazed that everybody around the world is all signing into this. And this presentation has given me the opportunity to reflect on some work that has been done over the last 5 years and check into where we are now. Diversity and inclusion in ophthalmology. I don't need to convince people here of the case for change, but I would like to share with you a story, and I think today's session has been very much about stories, perhaps something to give everybody some hope. If you visit the Royal Australian and New Zealand College of Ophthalmology headquarters in Sydney, Australia, you will see this board. And I'm quite sure that there will be some striking observations that people in this audience will make. In case you think that that was the Dark Ages, this is a photograph taken at the APAO meeting in 2018. And I find it really interesting that for the whole of the Asia Pacific region, there were no experts in vitreoretinal or glaucoma surgery who were female who could be found to participate in this panel. This ties in with the unconscious bias, that conscious and unconscious bias that has been described by the previous speakers. And you know, for the benefit of the audience, we didn't actually compare notes, but it is so striking how aligned our thoughts are on this, thoughts and experiences are on this. So we're dealing with a thing that there is a problem which has been invisible and perhaps even invisible to us. I mean, I have been accustomed to growing up and developing my profession in a very male-dominated environment, and I just didn't see that there was a problem. But of course, now we know that it is a problem. This was brought into stark relief in 2015, and it became something that the public cared about. A female vascular surgeon in Australia spoke out in the media saying that she would advise trainees to stay silent on sexual abuse, bullying, discrimination in hospitals, because the effect on their career would be damaging and that they need to get on with it so that they can succeed. Why did this meet the, you know, why did this resonate with the community? Well, of course, the community realizes that a toxic workplace affects patient safety. Initially, the College of Surgeons was in denial about this, as a no problem here. So they initiated an expert advisory group that actually did a survey and found that this actually was a problem. At the time, I was on the board of the College of Ophthalmology, and we also thought there wasn't a problem, but we initiated our own survey, which found that similar things. So overall, bullying, discrimination, sexual harassment and harassment was about nearly 40% in our community. At the time, I had read a book written by Catherine Fox, which dispels the 7 myths about women at work. The striking ones, they're all relevant. Workplaces are meritocracies. Well, of course they're not. If there's been 50 years of a College of Ophthalmology with no female presidents, that is not a meritocracy. The gender pay gap in ophthalmology, to my astonishment, was not exaggerated. Helen Danesh-Meyer has published on this. Quotas and targets are controversial, but they are possibly the only way of addressing inequity. And the pipeline myth is alive and well, because for the last 12 years, Australian universities have been graduating 50-50 male-female graduates, but only 30% of female trainees, only 30% of ophthalmology trainees are female. This needed to change. I saw this as an opportunity. The bullying and harassment thing was clearly a problem, but we needed to look at the underlying situation. At the time that this occurred, this was the representation of females. So the blue is the representation of females on the major committees of RANZCO in 2015. I also wrote a paper that addressed those 7 myths of women at work, and I did a literature review looking at each of those things. It found that those things were highly relevant to ophthalmology, which is exactly what has been supported by the 2 previous speakers. So our organization went from a stage of denial where the absence of women was not regarded as a problem or a core business issue, to realizing that there was a significant problem that needed to be solved, and commitment to a new culture. So the exclusion of women being recognized as a symptom of deeper problems requiring solutions that involved inside out change. I think my proudest moment was when these words appeared in the board papers, that a proactive approach to gender equity is pivotal to RANZCO surviving and transitioning into the future. There were various ways that we were doing this, and in this short time, we can't go into the details. But I think it is relevant that diversity was added to the risk register for our organization. And RANZCO committed to a goal of 35% representation on all committees and leadership bodies. Now, this was controversial. It was not aiming for 50-50 because that would not have been achievable, because less than 30% of females, less than 30% of ophthalmologists in Australia and New Zealand are female. However, it's also pivotal that when you reach a goal of 35%, that is when the conversation changes. One of the successes in leading to this process was the 8-step process of leading change, and that is Cotter's 8 steps. And it was a conscious decision to go through these processes. And I would urge you all, if you're initiating any sort of change management process, to look at these steps and apply them, because they work. So where are we now 5 years on? The target has been successful. We're not there yet, but these are updated results from 2021, where you can see that there has been a huge change in the female representation on all the committees within RANZCO. This has also changed the conversation. It has raised the awareness. It has changed policy, and we have changed how we approach selection into ophthalmology. There are a number of initiatives that have been changed by this. And giving the Women in Ophthalmology group a voice, and a powerful voice in influencing how they inform the board and council decisions has been very important in this. So the take-home messages with this are that as women, we need to be at the table. We need to recognise opportunity when it presents. Data is influential. We need to be able to present a coherent case. Quotas and targets work. You need to understand change management. You need to take a long-term view, and you also need to be willing to let others take the credit, because we can't do this on our own.
Thank you, Dr. Greene. I don't know how much the others know about your influence in RANZCO and APAO, but you really have made incredible changes, and they've been receptive to them. So thank you for being proactive about it and speaking up. And then I very much appreciate the reception you received, and how we now talk about RANZCO as being the model, and how can we get to where you guys are. So thank you for leading the charge internationally. I just want to make a comment that we are a little bit over time. We know we are, and we recognize that. We are having such a great time with the discussion, and we think it's really valuable, that we're going to continue on for a few more minutes. If you need to go, this will be recorded. I promise you won't miss it. You can watch the recording later. But Dr. Greene, I wanted to follow up with that. You clearly did a data analysis at RANZCO. You saw, you had the data, you went to them with the data. And then you were able to affect change. How do we get organizations, how do we get our organizations, our regional organizations, our subspecialty organizations, to see the issue of this lack of gender parity and other diversity, and then to act upon that?
I think we need to take the recommendations from all the speakers previously. We need data. We need to speak up. This is an invisible problem. We also need to make the connections as to why this is important. This is about access to eye care for women. If female ophthalmologists are available, more women will turn up to clinic. More women will choose ophthalmology as a career. So we have to have a systems approach to this. We need to take every opportunity to influence. We need to understand that we are on the back foot because of generations of inequity. We need to be at the table, not to be put off by this, not to be offended by it, but to speak up and be confident in the data.
Thank you. So we're going to have a brief discussion, but before we do that, I wanted to we have one last poll. And that question is, have you ever had an open discussion with your colleagues about unconscious gender bias? The first response is yes, often. The second is yes, rarely, but it has been well received. The third is yes, rarely, but it has not been very well received. And never, I need the right tools and or mentorship to do that. So I think we've learned a lot during this session. Thank you to all the speakers for the fantastic talks and for sharing your personal experiences with our group today. I think if anything, we now know the extent of the issue of this unconscious gender bias. And do we feel comfortable having those discussions? Have we had those discussions? And is there anything to do at? So here we go. We're going to have the poll results here. And we have 38% of the respondents said yes. Rarely, it has not been well received. So that's really unfortunate that they didn't feel like it was well received. And that's probably why they have not had further discussions. And then 23% said never, I need the right tools and or mentorship to do it. And then 19% for both yes, often, and yes, rarely, it has been well received. So we've got work to do there. And maybe that's one of the next things that we can work on as a group is how do we have these discussions? Just so you can see the results from last week from the Western Hemisphere poll, and it's very similar in the sense that that 34%, so about a third, said rarely, it has not been well received. A little over a fourth said yes, often, so that group was a little bigger. But in general, the biggest category in both the Western and Eastern hemispheres was yes, it has not been well received. So we've got work to do there. I'm now going to open it up to the question and answer session. We had a great question from the audience, and I wanted to make sure that we got to that. It was, what can we do against gender discrimination, which comes from senior doctors? What would be the right thing in terms of attitude and also the sake of education? So I'd ask that all of our speakers from this second section can kind of maybe address that. We'll start with Dr. Trinh. Dr. Trinh, do you have any comments for our attendee who was asking about what to do about the senior doctors?
So I think that's a fantastic question because a significant proportion of women, we're admitting, 50-50, but these women are really at the beginning of their careers. So, there's a significant proportion of us that are still at that very vulnerable and, junior position. And you frequently enter conversations where you exhibit examples of gender bias. And I used one of the examples in my in the beginning of my talk about, there was basically a mantle being suggested, and I pointed out that, look, it's really interesting in the history of the time that we've been running this very successful education session, we've not really had a female speaker. Do you think that we could perhaps think about having one? And it's not directed at anyone. It's not laying blame. It's just opening the door and that possibility. And as I said before, just going one step further and offering some suggestions just makes them take that pause. And sometimes that is all you need to get a foot into the door, to get them to think about something else. But I do find that, being receptive to listening, and I had a conversation this morning with some of my colleagues about, when you see a title saying, women in ophthalmology lunch or women in ophthalmology session, do you feel empowered to come along? Do you feel invited? what kind of perception do we, or is there any work that we need to be doing to be inviting more men to that conversation? Because we need male allies, we need male champions just as much as we need female ones. And bringing them into that change and empowering them is much more powerful than having that sort of, conversation that can deteriorate into an antagonistic relationship. That's my personal philosophy. Yeah.
Thank you. Dr. Sharma, do you have any suggestions for the generational differences and how much of it is a generational issue? I know you addressed a little bit of that in your talk. Or also, did you have any advice for those attendees who the majority of them who felt like they'd not had their discussions well received when they brought up the issues?
Thank you, Dr. Shriver. I'd like to answer that with another question that I saw in the question and answer. I see that there's a foreigner who had been trained in Nepal and who distinctly has mentioned that in Nepal, when the patients came in, they would prefer to have their eyes examined by a male physician, and irrespective of whether it was a doctor or the paramedical, they would rather go to the male personnel. So this kind of, like the discrepancy, the unconscious bias that the patient comes in, it is also there, it is present amongst us as well. I do not believe in stereotypes, but my response is still inculcated in my mind. So when I say that the generation gap, if we are talking about how the senior doctors and the junior residents, how they are interacting with this, how they are able to go forward with this kind of conversation, then what I suggest and what I see in my part of the world, in the places where I trained, yes, there is a system. The system has is such that it doesn't indicate a male or a female. It is less so prominent in indicating that this is a male person, this is a male, and this is a female working in this and that. But it primarily indicates the competence level. So if we have a system in all the academic activities and all the academic organizations, that a system is set up which measures the person in terms of the qualities, in terms of the competence, in terms of other educational achievements, I should say, other academic achievements, then we might be able to rule out the kind of bias that seeps in the mentor-mentee relationship. And like Dr. Trinh, she mentioned that if we have the male or female, that box where you indicate whether a male or female, if it is really dropped down, way down below in the form, or maybe even removed, that might also be going to help a lot in how the mentor and mentee relationship can go further. And the intergenerational gap, the bias that seeps in between, can be reduced with that.
Great, thank you. Dr. Greene, I think we'll close with one last question for you. With bullying and harassment has been seen more as a societal, cultural issue, how do we get our organizations and who felt like this was kind of out of their control and nothing that they needed to necessarily respond to, how do we can get their attention on it and get them to address it, and what role do they have in dealing with it?
Professional societies have a responsibility to demonstrate leadership. Professional bodies are deemed to have, and it's such an important role in society, that they are able to govern themselves. That is the privilege that society has bestowed on us. We are incredibly influential, both as societies, but also the individuals that make up those societies. If you think about all the patients that you see on a day-to-day basis, how influential we can be in changing dialogue. An example at the moment for me is I'm an ophthalmologist, but I spend a lot of time talking about vaccination for COVID. Should I or should I not have this vaccination? Family violence is an issue around the world. We have an opportunity to talk to people as individuals and to demonstrate leadership with this. So we should do it as individuals, but also as societies. And if we all stand up and speak from the same page and demonstrate leadership, I think we can change a lot.
Well, thank you. Thank you all for your time. Thank you for staying with us a little extra. It was just too good. I couldn't stop it. And I think that's a perfect ending, Dr. Greene. So thank you to our panelists, Dr. Trinh, Dr. Sharma, Dr. Greene, our panelists from our previous sessions. I very much appreciate your time tonight and having the opportunity to talk to you about this. I hope that we're able to have further discussions, and this is really just the cusp, and we're going to join together instead of having discussions as our small organizations or our regional organizations, really coming together globally and to having those discussions that way. So thank you again. I'd also like to take a moment to thank the Orbis and the CyberSite team for their leadership and technical expertise, the SEVA team for their multimedia work, and for you all for being here today.
Thank you all so much. I just want to extend my thanks to the panelists, to all the participants for a fantastic, fantastic session today. I am so intrigued by all the conversations and would love to see what comes next. And we thank you again for your time. Take care, everyone.